Thank you very much. And I really want to thank Novartis and the sponsors of this for inviting me to Mexico. It's very lovely to be here from Canada. I'm going to talk about the use of anti-CD20s in pregnancy and lactation. This is my brain center where my multiple sclerosis clinic is. Of course, I am speaking of my opinions. I will be speaking off-label because I will be talking about pregnancy. The slides are mine and the opinions are my own and do not necessarily reflect what Novartis promotes. My disclosures: I've accepted honorarium from various multiple sclerosis companies. This is a picture of the beautiful city of Vancouver where I live. So MS is very common in Canada. So in Canada, we have a small population compared to Mexico of only 39 million people, but we have a very large country. So we have about 4 people per kilometer square. About 1 in 400 people live with MS in Canada, or about 90,000 Canadians. I tried to look it up for Mexico, but the data is not very clear. Google said 18,000. I'm getting the sense that it's more like maybe 30,000 people live with MS in Mexico. Every day, 12 Canadians are diagnosed with MS. My MS clinic in Vancouver is one of the largest in the world. We estimate we have between 7,000 and 8,000 patients. Currently, we have about 3,000 patients on B-cell therapies, so we have an awful lot of experience. We've been using the B-cell therapies as we were the largest enrolling center from the pivotal Ocrevus study, so we have been using them for a very long time. So Anna is a 36-year-old female. She's otherwise healthy. 3 months ago, she had left-sided numbness, mild imbalance. It resolved without treatment. Her MRI showed periventricular juxtacortical lesions. She had 1 GAD lesion, no spinal cord lesions. She had wanted a pregnancy when she developed MS and still wants to go ahead with this plan. She asks if she can do this safely. So fortunately, we have a lot of data now about the management of pregnancy in MS, and we can effectively apply that. So we have longitudinal pregnancy data registries. We have the safety and therapeutic safety registers from the phase 3 studies, from the open label extension, surveillance registries. So we can now use these to help advise our patients. I believe in discussing this in a very positive format. Women planning pregnancies have choices. We need to offer them choices. They should be counseled about pregnancy at their diagnosis. They should be offered options around managing their disease during pregnancy planning and beyond, and they shouldn't be denied therapies because they are of a pregnancy age. Most women actually do well with regards to their MS and pregnancy, and we don't have to think that pregnancy may have a negative outcome for women with MS. So we know from the original PRIM study that is shown on the left side that historically relapses go down during pregnancy, but then postpartum, we can see this significant increase above their baseline rate. On the right is a more recent graph where we see just overall lower rates of relapses, but we still see that they increase postpartum. More DMTs are being used around pregnancies. So the first bar graph shows before 2005, when most patients were not on a DMT, and we can go to the last bar that shows most patients were on a DMT, and many in the top red-brown bar did not have a washout period, so they were safely protected up to the time of pregnancy. This is a graph showing an analysis from the clinical studies with ocrelizumab that shows very good control of relapse rate pre-pregnancy. It goes down during pregnancy, but postpartum, we see a maintenance of this very low relapse rates. We do not see any increase if ocrelizumab was used prior to pregnancy. So pregnancy does not have to result in long-term MS disability. Some studies earlier, it suggested that women would fare worse if they had pregnancies. Current data, including the recent MS-BASE real-world study, perhaps suggested maybe a protective effect, but I think this is very difficult. I think, if anything, we can come to the conclusion that there is no long-term harm with pregnancy. MS does not affect fertility. We can see sexual dysfunction, which might delay pregnancies, and that must be considered. And we're also fortunate that oral contraception is not a risk factor for the development or worsening of MS. Contraception should be discussed with women with MS. And fortunately as well, there's no interaction between the oral contraceptive pill and the medications that we use. MS does not affect pregnancy, labor, or delivery. So a large study with almost 3,000 pregnancies in women with MS compared to almost 60,000 women without MS show no difference in complications like eclampsia, diabetes, no difference in rates of stillbirths or preterm births. We do see a slight increase in C-sections, but this is mostly because obstetricians get a little bit nervous and tend to order a C-section earlier, and we found this in a Canadian study. We do see a slightly higher incidence of smaller babies for gestational age. MS should not affect delivery. Women have the same choices. They are not high-risk pregnancies unless, of course, they have high levels of disability. And contrary what some anesthetists still believe, epidural anesthesia does not increase the risk of a relapse. And monoclonal antibodies can be used through pregnancy, but they may trigger the need for some hematologic monitoring in the infant. So I think education is needed to help couples make family planning decisions. We have seen that women with MS overall seem to have a lower rate of pregnancy. This can be due to physical and psychological barriers. Many couples choose that maybe fatigue has so much fatigue, they do not want children. But at least some of the decisions that people make against having a child comes from a lack of knowledge. And 35% of those not wanting to have children cited that they were worried about passing MS on to their children. So couples should be counseled that genetic risk of MS is low. And we always do this in our first education session, but then I'm always surprised years later when I come back to talking about pregnancy, how the women will say, well, no, but my child has like a 30 or 50% chance of getting MS. And they're very surprised when I again reiterate that they have more like a 3% chance of MS. So I think it's something that we always have to remind people about, that the genetic risk is actually low. So pregnancy planning starts at diagnosis. As was mentioned in the earlier talk, all patients should get baseline blood work for any DMT. They should be vaccinated so that they can be on any DMT and switch to any DMT without a delay. And should inadvertent pregnancy happen, you are prepared. Active MS should be stabilized before planning a pregnancy. Ideally, we like to see no disease activity for a year, but in a pinch, 6 months will do. Treatments that offer disease control up to, during, and after pregnancy should be considered. So going back to Anna, she was advised to stabilize her MS before pregnancy. When we were talking to Anna, we had to talk about the risks and the benefits of therapy. And I think when people are talking about pregnancy planning, they focus on the risks to the baby, and they forget about the benefits to the baby if the mother maintains disease-modifying therapy control. There is a risk to the baby if the mother has relapse, is unable to care for the baby, if rescue medications are needed. There is a lot of advantages for the mother, of course, to be on a disease-modifying therapy up to pregnancy. And this can be done while not risking the fetal health. I think it is very important to recognize that high-efficacy therapy is needed as early as possible in the course of MS. This MS-based and Swedish database study showed that even delaying therapy by a couple of years resulted in a 50 to 66% worse disability outcome than the earlier treatment. And so in all fairness, we don't want to have women delay and not have that effective early therapy because of pregnancy plans. With ofatumumab, the Esclerosis study and the extension showed that we can get very, very low relapse rates, about 1 in every 20 years per 100 patient years. So we're seeing very, very minimal disease activity. But what we're seeing is that pregnancy and the thought of pregnancy causes a lot of therapeutic inertia. So from this French database registry, they saw that women in childbearing years had a much lower rate of the use of DMTs in general, and even lower in high-efficacy disease-modifying therapies compared to men. And then you can see on the bottom line for anti-CD20s, quite a bit lower compared to men, whereas a little bit more, perhaps, use of natalizumab, and definitely higher uses of the low-efficacy therapies like interferon and glutaramine acetate. And this can be seen graphically, with the bottom line being high efficacy and the top line being low efficacy therapies, that there is a lower use. It comes up slightly after pregnancy, but in fact it doesn't actually catch up to male use. So when we look at the biology of MS, we know that initially we are seeing the peripheral response. And then we start to see the more compartmentalized response. Well, our drugs are very good in the peripheral immune response. And we're not doing so well once we have this more centralized, compartmentalized inflammation. So we really need to prevent that. We need to prevent that seeding in the brain that then can lead to progression. And again, that is done early. For women, that means that therapy needs to be in those years where they potentially could have pregnancy. So what can we use in pregnancy? Well, glutaramine acetate, interferons, and dimethyl fumarate are all safe to use up until the positive pregnancy test. With glutaramine and interferon, they can be continued throughout the pregnancy, and if you want them to have the protection for breastfeeding, then you must continue it through pregnancy and continue it through breastfeeding. Dimethyl fumarate, of course, should be stopped as soon as there's a positive pregnancy test. Drugs that must be discontinued include teriflunomide, which requires a washout. Cladribine, of course, is immune reconstitution, so patients can get pregnant 6 months after their last pills, but all of the S1Ps need to be stopped, and they really do need to be stopped much before the pregnancy is planned. This is a very sad case of one of my patients who stopped her own fingolimod because she wanted to get pregnant. She had over 30 GAD-enhancing lesions in her brain and spinal cord, and she has never been able to have a pregnancy, of course, because she has significant disability. This is what we want to prevent. I have to say I no longer use S1Ps in my women of childbearing age. I feel there are better options. But if you are using them, you must know that they do have a possible teratogenic effect, that we must get women off of them, I think, at least 6 to 12 months before the pregnancy is planned, and they need to be put onto another therapy while they're discontinuing their S1P. They could go on to cladribine, they could go on to natalizumab as long as it's continued through pregnancy, but ideally the easiest is actually an anti-CD20. It's probably the nicest transition, and then they're already set up for pregnancy. So I do use ofatumumab when I am transitioning people off of S1Ps. They actually do have a fairly quick onset of action, as seen by the lymphocytes dropping. And the nice thing is that you're giving 3 injections and then another one in a month. And so as the patient reconstitutes their lymphocytes, they're getting the effect of the B cell depletion continuously. It is also something that the patient has in hand. So as opposed to waiting for infusion and not knowing, are the lymphocytes coming up? Is the infusion going to happen? They've got it in hand. You tell them when to stop their S1P, and they can do their injection, which I think leaves a lot less room for errors and delays and therefore rebound. So cladribine is a nice drug to use before pregnancy, and women can take their 2 oral courses and then must wait 6 months to attempt pregnancy. And then, of course, it offers protection through pregnancy and through breastfeeding. Monoclonal antibodies can be considered in pregnancy. They do not cross through the placenta in the first trimester. It is an active transfer of IgG through the placenta, and we start to see that in the second trimester, and then very much so in the third trimester. So this is a picture of the development. You can see initially the blastocyst. There is no exposure to monoclonal antibody because there is no IgG, because there is no placenta. After week 13, we start to see the placenta, but you can see there are no villi on the vessels. And then by about 20 weeks and beyond, we get the development of the villi that have the receptor on it. And the graph on the right, you can see the exponential increase in IgG or antibody transfer through to the fetal circulation. So the prescribing instructions or the product monograph for most countries have that a woman should not attempt pregnancy without washing out for 6 months. Oh, sorry, this is natalizumab. So I'm talking about natalizumab first because it was the first monoclonal antibody that was used in pregnancy. There are no fetal abnormalities as a result of natalizumab, but the problem is that there is a high rate of rebound or high disease activity if you stop natalizumab before or during pregnancy. So expert panels recommend if you continue natalizumab, you must continue it to about 32, 34 weeks and then resume quite rapidly after birth. This is an MS-based study, again, that shows in the pink that you can have low levels of disease activity using natalizumab, but if you discontinue it prior to or during pregnancy, you have a very high rate of postpartum relapses, whereas in the green, you can see if you are using an anti-CD20, you have very low levels throughout. So with ocrelizumab, the prescribing instructions indicate for most countries that you should have 6 months after infusion before you attempt pregnancy. Most of the experts who work in the area of pregnancy and multiple sclerosis recommend that a patient use contraception after their last infusion for 6 weeks to 3 months or 1 full menstrual cycle. Infants should be assessed for a CBC if there was exposure to the monoclonal antibody during pregnancy. I'll go through that a little bit more. Ofatumumab, again, although the label indicates 6 months before attempting pregnancy, most experts recommend either timing the injection with the menstrual cycle so that you know you're not pregnant at the time of the injection, or doing a pregnancy test at each injection if they're not using contraception. So this is graphically, if a patient were to get their infusion or their ofatumumab injection on day 1 of pregnancy, we can see with the red star, that would be where ofatumumab would be cleared if they took no further injections. It is well before the dotted red line that shows where it is, where we start to see transfer over the placenta. However, with ocrelizumab, if you did your infusion on the day you were pregnant, you would see that we're just starting to get some transfer of the monoclonal antibody through the placenta circulation. So ofatumumab is very safe. Ocrelizumab appears fairly safe, but ideally we would recommend patients not be getting pregnant at the time of their infusion. So this is what we use in Canada, and it's very similar to what's often used in America and Europe. What we suggest is a woman have a negative pregnancy test when they get their ocrelizumab infusion. At about 6 weeks, they can start to attempt pregnancy. If they are not pregnant at the time of their next infusion, they need a negative pregnancy test. They can infuse again. They can wait 6 weeks to 3 months or a menstrual cycle and then try again. And we often lengthen that out and tell patients that they can delay their infusion for 8 or 9 months if they've been on an anti-CD and are stable on it. With ofatumumab, if you time the injection with the menstrual cycle, it's very easy. They can inject at each menstrual cycle. Otherwise, they would take a pregnancy test each time before they do their injection. So Anna had decided to start ofatumumab. She felt this was the best choice, and she was going to delay pregnancy by about 6 months, which was reasonable. However, Like 50% of women, she became pregnant. So accidental pregnancy is very common. 40 to 50% of pregnancies are unplanned, and we have to keep this in mind. So again, if we look at if a woman actually recognized that she was pregnant at 6 weeks gestation, this graph shows what the exposure would be like. With ofatumumab, if she recognized she was pregnant at 6 weeks, took no further injections, the drug would still be cleared before there is transfer over the placenta. With rituximab and ocrelizumab, there would be a second trimester exposure. So I see the advantage of ofatumumab in that it's easier to time with menstrual cycles, and because of the shorter half-life of the drug, we also see that it has got that extra safety margin. So benefits and risks can be balanced. I think we have good data around fetal outcomes. So we know that this is effective for mothers at preventing relapses, preventing disease progression, and we have to know that it is also very safe for the fetus. So the potential risks include congenital abnormalities, B-cell depletion and decreased vaccine response in the baby, and theoretically with the mother, if she's got hypoglobulinemia, there could be an increased risk of infection. So the ocrelizumab pregnancy registry data is now a very large and long-standing database. In this, and I'm not going to go through all the data, but what it compares is what we call non-exposed pregnancies. So women who were on ocrelizumab, but their pregnancy occurred after the 6-month clearance time. And exposed is those patients who were pregnant and their last menstrual cycle was 0 to 3 months, or sorry, the exposure was 0 to 3 months before their last period, or they were actually exposed during pregnancy. So the non-exposed who had been on ocrelizumab stand as a very good control for those who were exposed in pregnancy. And what we see with this was that there really wasn't any differences in any fetal abnormalities, fetal death, spontaneous abortion, stillbirth, or small for gestational age. So the data is very reassuring, but we have to keep in mind that when we talk about exposure, the exposure really was very early exposure, and I don't think that translates to if you were to give an infusion in second trimester. There are many case reports of infusions done in second trimester with rituximab, with ocrelizumab for MS and other diseases, and in fact, the babies were all fine as well. So the Minori study is a prospective study, and this was presented by Dr. Hellwig in ECTRIMS 2024, and this was actually looking at mothers whose babies were exposed in pregnancy, and looking at the blood cord levels of ocrelizumab. And what we could see from this was that the levels were all very, very low, that there really wasn't any fetal detection of ocrelizumab monoclonal antibody. And then as well at birth, they looked at the B-cell levels in the baby, and they were all normal. So again, this is quite reassuring to actually have the blood studies done to show the safety. Again, only a few of these were actually exposed in the first trimester. Most of the exposure was 0 to 3 months before the infusion. So we have similar data with ofatumumab pregnancies. There were retrospective and prospective cases. And again, there was no significant increase in fetal abnormalities or poor birth outcomes. German registry data presented at the American Academy this year looked at 11 pregnancies with ofatumumab exposure. The mean exposure was about 15 days after the last menstrual period, with a range all the way up to 47 days. About 72% had exposure after their last menstrual period. And again, what they found in cord blood and infant blood was that there was neither B-cell depletion nor lymphopenia. So it was concluded that we did not tend to see a reduction in B cells or lymphocytes in the fetuses and babies that had been exposed during pregnancy. So again, we're starting to see reassuring data around the safety. There is one case that was presented, and it's quite interesting because it was a mother who didn't recognize that she needed to stop the ofatumumab injections through her pregnancy, so they were taken throughout the entire pregnancy. Mother did great. She had no relapses. She had no increase in disability. And in fact, the baby, who had an estimated gestational age between 32 and 35 weeks, had normal B cells and normal lymphocytes. So again, even with continuous ofatumumab exposure through the pregnancy, the baby had a normal immune system. So what about immune suppression in pregnancy? Do we have to worry about the mother? Well, pregnancy itself is an immune suppressed state, so women are at an increased risk of infections. The ofatumumab perhaps offers a bit of advantage here because the marginal B cell zones that are expanded in pregnancy can compensate for immune suppression, and it is felt that perhaps ofatumumab affects these less than ocrelizumab. I think that's theoretical. I think the other aspect of ofatumumab is it does come out of the system because of its shorter duration, out of the system a little bit sooner. But interestingly, there really aren't any reports of infections in women during pregnancy on the B-cell depleting therapies. So we actually don't have a lot of evidence to suggest that there's the increased risk, but we do have to keep it in mind, and we do have to discuss it with the mother. All right. So we need to discuss the management for breastfeeding. So even if your patient is not on a disease-modifying therapy at the time of pregnancy, the risk period is postpartum. And I think this is the easy one. I think it's very easy to put a patient on a highly effective therapy postpartum. So breastfeeding, first of all, should be encouraged. There's many benefits to the infant and to the mother. For the infant, things like reduced risk of infection, to the mother, bonding, reduced postpartum hemorrhage. WHO recommends exclusive breastfeeding for up to 6 months. We like to promote this. It's not always easy for moms, and so we ask that they try exclusive breastfeeding, but we have to allow a little leeway, especially in our patients where fatigue might be a significant issue. So studies have shown that breastfeeding reduces relapse risk itself. So there is some benefit with exclusive breastfeeding. Exclusive breastfeeding means no formula supplementation at all. When there was formula supplementation in some of the older studies, they did not see the benefit of breastfeeding. But it's nice to be able to say to mom that doing something that's healthy for her and the baby will result in a lower relapse rate. It's about 43% reduction in some studies. Unfortunately, it's time limited because quite often supplementation occurs. So I like to consider the use of a disease-modifying therapy in this very high-risk period. So many DMTs can be used safely during lactation. The therapeutic lag for therapies like interferon and glutamate don't really make them a good choice unless they have been used throughout the pregnancy. But it does take 3 to 6 months for these drugs to be effective, and they are of lower efficacy. So I don't tend to use them at all for breastfeeding. I haven't probably prescribed an interferon or glutamic acetate for quite a number of years. I have to admit, almost all of my patients are on B-cell therapies. But if I had to start somebody if somebody was on one of these therapies before pregnancy, postpartum, I would encourage a higher efficacy therapy that has a rapid onset. When we're looking at risks to the baby, we look at relative infant dosing, and it's generally suggested that it should be less than 10% of the maternal dosing for toxicity. So again, MABs are large molecules. There is very low levels found of monoclonal antibodies in the breast milk because IgG does not actually go through breast milk. It is IgA that goes through breast milk. Then any small amount that does go through will be going into the baby's gut and is digested. It's a protein. So there's negligible amount of monoclonal antibodies absorbed from the infant. So if we look at relative infant dosing, it is very low with monoclonal antibodies. It's generally much, much less than 1%. It can be higher in the colostrum phase. The colostrum is the first 2 weeks. So those are the considerations. We usually suggest a mother waits 7 to 14 days, usually 14 days before starting on a monoclonal, just for that margin of safety. The only caveat to that is natalizumab, because the mother had her last infusion 6 weeks ago. She needs that natalizumab now, and so I think natalizumab can be infused anytime after delivery, as quickly as possible, in fact. So the monoclonals are a good therapy. We've seen it in data on breast milk from rituximab, ocrelizumab, and ofatumumab, that the relative infant dosing is less than 1%. And then in the latest Sopranino study, where they actually did look at the levels in the breast milk, and they looked at the levels of B cells in the babies, we saw a very, very good result. So the levels of Ocrevus in the milk were infinitesimal to very, very minimal, of 0.3%, which is well below the 10% mark. They were not detectable in the infant serum, so no levels detected in 9 out of 9 infants. And then B cells were also performed on a subset of the babies, and the B cells were totally normal. I mean, we expect this if you have that low of a level in the milk, but it was nice to see this properly done in a study so we can see minimal levels in the milk, normal B cells in the baby. Ofatumumab, there's also another study of 12 breast milk samples with ofatumumab, and again, the ranges were extremely low, and 0 out of 5 infants tested with ofatumumab had no B cells. So again, reassuring data for both ocrelizumab and ofatumumab. So how do we retreat a patient postpartum? Well, with ocrelizumab, I have to admit, I don't do a divided dose. If they had previously been exposed to ocrelizumab, I just give the 1,000 milligrams 2 weeks postpartum. If they've not had previous exposure, then you do the divided dose. The pre-medications can be an issue, so I have to carefully explain to the mothers about the pre-medications. The methylprednisolone can reduce milk production, but that's fairly short-lived. The baby will get some methylprednisolone, and that is safe for baby. We do suggest that they pump and dump right after their infusion to minimize this, but since most mothers do not have a lot of milk production at that point, they haven't stored up a lot, really the baby needs the breast milk. It is safe to breastfeed even without pumping and dumping. Antihistamines are safe, and the antipyretics are considered safe. However, that's a lot of extra drug exposure, and many moms feel uncomfortable with that. I think even day to day, our patients prefer not to have these. And so ofatumumab, I think, offers huge benefits postpartum. So you don't have to worry about pumping and dumping. You don't have to worry about exposure to steroids. And the nice thing is you don't have to worry about arranging an infusion. I don't know how it's like here, but in Canada, I don't know when the mom's going to deliver, and then I have 2 weeks to try and set up an infusion. That's challenging. And so then it often is, a little bit of anxiety around when is the infusion. For most women who don't have highly active disease, I mean, even a month later is fine, but it is a little bit more stressful. With ofatumumab, they've got the drug at home. As soon as you say go, they're able to do their injections. They don't have to worry about who's going to take care of baby, how long they're going to be at the infusion site. It's just nicer. It really is quite nice postpartum, and I find that this is one of the indications I really am pleased to use this medication. So overall, we can see that the use of DMTs improve maternal postpartum outcomes. The only bar in pink that goes high is when you discontinue natalizumab. The next bar in green is we don't see the same good level of disease control with dimethyl fumarate, but we see very good control with B-cell therapy in the green and with natalizumab as long as it's continued up to 32, 36 weeks and in postpartum. So we're seeing very low levels of disease activity, which is really assuring because this is a very risky time, and we know that the women don't have to go through the risk of, when they're planning pregnancy, being on an ineffective drug, no drug, having a risk of relapse while they try and get pregnant, which is a very common scenario. And we see it more so as women are delaying pregnancy now. They're a little bit older, it's harder to conceive, they're often spending too much time off drug if we do not offer them effective and easy disease-modifying therapies. So what happened to Anna? Well, she had a relapse in pregnancy, so naturally she was fairly keen to start on the ofatumumab postpartum. And she actually did very well and has had no relapses and had complete stability. So I thank you very much.